Welcome to your Module 7 lecture on the very exciting topic, cross-sectional studies, case reports, and case series. So hold on to your pants. It's going to be a good one. Basically going to do the same run through we have on the other study designs. We're going to learn about them, understand them. We're going to understand how they might be able to help with causality assessments, and how we actually assess for that within these types of studies. And then finally, critically analyzing them and making sure we can understand their uses and limitations for clinical care. As we do with all of our lectures, let's start out with a little bit of a case here that we can think about as we go through these types of studies. So here's our clinical dilemma that we have to answer through the literature. Pharmacist burnout. The research question: as an aspiring pharmacist epidemiologist, you're increasingly concerned about the burnout in the medical field. You wonder, is burnout also prevalent among pharmacists? So here's the challenge. You got no funding. You can't do a randomized controlled trial here. There's no retrospective data. You can't do any of this. All right? So you're going to need to conduct a survey to gather this information. So the solution you figure out in your brilliant brain after taking this class is to do a cross-sectional study. It'd be perfect for this scenario. You send out a survey, ask pharmacists how they feel, and then look at the results. All right? So this scenario really illustrates a practical application where you can't use randomized controlled trials or case controls trials or cohort trials, and you have to apply the lower quality trials but still highly useful trials, in this case a cross-sectional study, to answer your question. Now, what is a cross-sectional study? So it's basically an observational approach where both exposures and outcomes are assessed simultaneously, and here's the key: at a single time point. It's cross-sectional. Single time point, okay? We commonly see it with survey studies, with disease prevalence studies, or if you are really limited on a budget or you need to get pilot data on those early types of studies. Really, they have limited ability to establish causality because we have no temporal relationship. We're doing everything in a single time point. So there's only so much we can say. They're associated, but that's the extent to which we can go. So the internal validity is even limited, and it generally focuses on existing cases or whatever you're looking at. You're not going to be waiting for new cases to pop up. So whatever is currently existing at your cross-sectional time point is what you're going to get in your study. On our beautiful hierarchy of evidence, you can see it falls nearly to the bottom, just above case reports. So cross-sectional studies, certainly not near the gold standard, but as we will see, still has some uses. How do you design a cross-sectional study? Well, just like most other studies, you have to select a population. So you're going to choose a representative sample of the target population. So for the burnout study, it would be pharmacists in different practice settings. You would then measure the exposure and or outcomes, because generally you're doing both, okay? So your exposure here would be what? It would be something like work hours or job responsibilities in our pharmacist burnout example. Then the outcomes would be burnout symptoms, so maybe a survey or something like that. And you give it all of these, you assess on a single questionnaire or survey. And then you take all that data and you analyze the associations, okay? You can't establish causality, just associations, but you can still find some associations. And then you describe the results with prevalence data or associative correlation statistics, which we'll go over. And as I've already said 3 times, we really can't establish causality, right? Because there's no experimentation. That's one of the things we always look for in this class. There's no temporal sequence. It's one time point, a single time point. And you can only show associations between variables, okay? So it really is not checking many of those boxes we're concerned about in this class. When we look at that example, a pharmacist burnout, we can see in a cross-sectional study of pharmacists in the United States, 30% of pharmacists report symptoms of burnout. The conclusion was burnout is prevalent amongst pharmacists. So the limitation here is you can't really determine what specific workplace factors cause burnout, or if burnout leads to perception of those workplace factors causing it, things like that. You can't go back and forth because it's a single time point. That would be for a future study. So they're cross-sectional studies. They have their limitations, but they're particularly useful. Again, if you're limited on budget, if you're trying to assess current states of practice or generate pilot data for future studies or for health policy. And that's where you're going to be using cross-sectional studies. So here's some strengths and weaknesses of cross-sectional studies. I won't even say the weakness again because we've already gone over it 4 times. Key strengths here, it is good for describing current states of whatever you're looking at, so practice or disease burden, and it provides that foundation for future research, helping you to generate hypotheses. So remember, it's always a snapshot. That's what I always like to say when I used to do cross-sectional studies during my postdoc. It's a snapshot, but that in every limitations. You could look up my papers. I guarantee the word snapshot's in there. And a snapshot's good for giving you exactly that. Just a look, a little glance into whatever question you're trying to answer, and hopefully in the future you can do a more rigorous study to prove that the association you saw with that snapshot is actually causal. Just as a refresher here, cross-sectional studies only can do prevalence, okay? And do we remember what incidence versus prevalence is? Well, incidence, remember, are the new diseases that come over a specific period of time in a population. So inherently, cross-sectional studies can't do that because they're only a single point in time. But they can do prevalence fairly well because you can assess disease burden at a specific point in time. Being lower on the pyramid or the hierarchy of evidence pyramid, it's certainly going to have some biases. Some of the big ones we see with cross-sectional studies are reverse causality. So again, it's a single point in time, so you can't tell what led to what. Because just because you think your exposure led to the outcome doesn't mean for some reason the outcome didn't actually lead to the exposure. You can't prove that otherwise. So reverse causality is an issue. And an example here I gave was in a study finding an association between antibiotic use and kidney dysfunction, it's unclear whether the antibiotics caused the kidney dysfunction or if the impaired kidneys led to higher antibiotic levels. See, you can't prove in a cross-sectional study. Incidence prevalence bias, so basically you can have these types of skewed associations between the exposure and the outcome when prevalence is used to estimate exposure instead of incidence. So here an example we might see is in a cross-sectional study, we might underestimate a relationship between smoking and emphysema because patients with emphysema already have quit smoking by the time of the assessment. So we can't capture that. We think maybe they have emphysema for some other reason, but actually they just quit smoking because they ended up with emphysema. And finally, selection bias is a big one with cross-sectional studies. It's basically when you target a population that doesn't actually represent the larger population you're going for. So for instance, in the burnout of pharmacists survey, maybe you only surveyed pharmacists who attend a professional conference. And that may really be those type A high achievers who go to conferences, right? Because who wants to go to a pharmacy conference? Let's be honest. Only those people who really want to learn about pharmacy, and maybe they're predisposed to higher burnout, or maybe it's the reverse. Maybe all the people who don't have time to go down to Florida and enjoy a conference are actually the ones being burned out because they're working 60 to 80 hours a week. So that would be selection bias. One of the big issues with cross-sectional studies, how do you actually sample your target population? Really here you have random versus non-random sampling. So random sampling means you basically have a selection process where every member of your target population has an equal chance for inclusion. So you're trying to spread the net wide enough that randomly you're going to get a good representation of the population. So you could do it just simple random, so completely random selection, or you could do stratified where you're looking at certain subgroups. The big advantage here is it provides a representative sample with minimal bias. Non-random sampling is you're just doing convenience-based sampling, and so you're just looking for participants that are already ready. So maybe pharmacy customers during your shift. Obviously, you're not going to get any customers that aren't coming during your shift, so that's going to cause potential limitations where you may not represent target populations. If you don't work on the weekend, for example, and you're trying to do a study, you're only going to get weekday people, and they could be substantially different from people that are able to come in on the weekends. Or you could purposely select participants with desired characteristics. That's called purposed sampling, and that's another non-random sampling technique. There are a few other observational study designs that can include a temporal component. So for example, pre-post studies, basically looking at a sample population before and after an intervention like measuring blood glucose in patients before and after 6 months of pharmacy counseling sessions. You could have time series, so you're going to analyze multiple observations over a given amount of time. So looking at something like tracking statin prescription patterns before and after a key medication becomes generically available. So you're looking over time. And then ecological studies, you're comparing groups rather than individuals. All right, now we've talked about cross-sectional studies. Let's transition over to case reports and case series. And these sound exactly what these are what exactly they sound like. So they're just detailed documentation and presentations of unique patient cases, singular, or collections of cases that are similar. They're generally always retrospective. I don't know if I've ever really seen a prospective case study. Maybe one. A few are out there. And they're descriptive in nature, so they're not going to have like a statistical section. They have limited validity because, right, you can't control for confounding. You're not really doing any sort of causal or even associative assessments in there. But their primary function is to generate questions and hypotheses for future research, especially with rare things. So what could be a clinical dilemma here that you could use a case control or case study or case series for? And that might be something like cannabis hyperemesis. So here's the scenario. You're an ER pharmacist. You encounter frequent basically cannabis user who's admitted with cyclic vomiting over 2 weeks. Her symptoms improve only with hot showers, which activates TRPV1 receptors, the same receptors that targeted by capsaicin. You really came up with an interesting theory there. So your intervention, based on physiological reasoning, you administer topical capsaicin. The patient's nausea and vomiting resolve within 20 minutes of application, suggesting a potential therapeutic effect. What conclusions could you draw from this single case observation? Can we determine that capsaicin is an effective treatment for this cannabinoid hyperemesis syndrome? So this is kind of like a starting point, right? You can't do an entire study on this because you are really flying in and off the ropes with a hypothesis to treat this. So maybe what you do here is you go ahead and establish at least some literature with a case report. Case reports generally look like all the studies we do, except for they're more single in nature, meaning one patient or a set of patients. So you're identifying unique or instructive cases with unexpected presentations, treatment responses, or outcomes to report on. Then you describe what happened with that patient. What was their state before whatever you're looking at happened? What was their state after? You're trying to present all the clinical information so that you can give it a complete picture of the case that you're reporting on. And then you review that against the existing body of literature. This is always a key portion of case reports, and it must be in there. Finally, you propose some mechanisms or hypotheses that can spur future research on your topic that you're reporting on. Although I didn't show the hierarchy of evidence pyramid, and I should have, it's at the bottom. So there's definitely some limitations here. Obviously, you can basically have no causality established here. There's no experimental control. There is no temporal sequence, really. I mean, I suppose there is, but it's very minor at best. And you can really provide no comparison between groups because it's just a case report. It's a single patient or a series of patients. So with the example of cannabinoid hyperemesis syndrome, there was a case series of 3 patients with this condition that improved after capsaicin application. So we can only conclude that, one, they did improve after that capsaicin application. You could say, well, this leads us to hypothesize that capsaicin might be beneficial for targeting CHS through those receptors we talked about earlier, and that controlled studies are needed to establish causal efficacy here in order to have it be a standard recommendation for these types of patients. Overall, the real strengths of case reports is it's really good for really rare things or things that haven't been described in the literature, for novel, new conditions or treatment responses that you just can't find anything for in the literature. And it's valuable for generating hypotheses for future research, and it can provide detailed clinical context that could be absent in larger studies because it should be a really comprehensive report on those patients. What are the weaknesses? Obviously no causality. There's lots of biases. One of the big ones being that publications don't really like to publish case reports, or there'd be a million of them, so you actually don't see them that often. They have really limited external validity because it's just one or a couple of patients, so we don't really know how this applies to the population at large. And there's no statistical analysis that would help control for, random error and the other types of biases we've talked about in this class. There is a scale out there to help you understand through a case report whether or not an effect of the drug was really, or at least an outcome that you're reporting was really due to the effect of the drug. Okay, so it's helping you to assess what degree of confidence can you say from the case report study that this side effect, for example, is due to drug X. Okay, and you can see here all the questions that it asks, all the way from are there previous conclusive reports on this down to what was the adverse event confirmed by objective evidence, and you get scores here. You either get a +1 for a yes, generally 0 or -1 depending on the category, and you can see how you have to assign it here. Now, depending on the score you get from the Naranjo scale, you can actually kind of give a somewhat confident assessment in terms of whether that adverse drug reaction is actually due to a drug, right? Because everybody reacts differently to drugs. So just because it's not in the drug label doesn't mean whatsoever that that's not a drug side effect. So if it's a score greater than 8, it's probably a definite one, high probability. Probable is 5 to 8, and possible is 1 to 4. Less than 0 or 0 is unlikely to be attributed to the drug. So this helps, and you will see these generally submitted either within the case report or as a supplemental information to help you assess from the case report how likely this reported adverse drug event is actually due to the drug itself. Since it's a case report, again, can't do causality, but this scale kind of helps us give some sort of degree of confidence in the case report's findings. We've gone over this previously, but this is a good place to bring this back up. Why do we always need groups in studies? Why are case reports and case series so limited with their lack of groups? It's because of all these issues that arise when you don't have a comparator group to compare your results against. Okay, you can have placebo effect, so some people just get better over time, and that has to do with regression to the mean, like we learned about, or the natural history of disease. These things always are present in studies, which is why you need to have some sort of control group to compare against, or else, again, your results are hard to decipher at best. There's some readily apparent biases from case reports and studies. I already mentioned that journals don't like to publish them, so it's very unlikely you'll see case reports, especially negative ones, and only positive ones will be out there. There's usually selective reporting, meaning that you're only going to get interesting case reports out there in the literature. You're not going to get kind of a humdrum case report, maybe even of a non-listed side effect of a drug, but everybody knows it causes it. Selection bias means that you're only reporting on one or a few patients, so who knows what type of patient this is, their true background, their genetic predispositions, their environmental stressors, all these things that can go into it. It's really hard to say there's much external validity at all. And then, because there's no statistical analysis, observer bias certainly comes into every case report because you, as the author, have to interpret the findings, and you have no objective way of doing this other than comparing it against the literature. So the common uses of case reports and series that we see is for identifying pretty much disease states that haven't been identified before, for new or rare serious adverse drug reactions, and that's where you see the Naranjo scale, maybe novel treatment approaches or combination approaches that we haven't seen before, and for quality assurance, so practice errors and things like that that'll help improve treatment within hospitals, for example. Here's a summary of the strengths and weaknesses of case reports and series. We've kind of gone over this as we've gone through these slides. So again, rare occurrences, new adverse drug events, hypothesis generating, detailed clinical context are all strengths of case reports versus weaknesses, right? No causal inference, lots of biases, no statistical analysis, lack of external validity, and maybe even internal validity. All those things are weaknesses to case reports. All right, so as we take away from this lecture, just remember, just like you prepare for every lecture for the upcoming exam, you want to know all the study design characteristics. How do you pick and choose between them, their strengths and limitations, and how good they are for their causal assessment and where they land on the hierarchy of evidence. Just remember, as we've learned about all these studies, and we've kind of wrapped it up now in this first half of the course, it's really important for you to keep these in your mind. You're going to see this over and over again. One day you're going to have to go to the literature, and it might just be for your family member. Maybe it won't be when you're dispensing at whatever community pharmacy, but maybe it will. And be able to use these skills appropriately and in an expert manner will certainly be something that everyone will come to you and want you to help them with someday at some point in your life.